الو 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 دكتورة، الو الو. الو.
You know what? Can we put it on the...
Good afternoon, ladies and gentlemen. It's with great pleasure to introduce you Dr. Joseph Khan. Dr. Khan completed his prosthodontic and implant surgery training from Loma Linda University. He's currently a professor and maintains a private practice as well. Welcome, Dr. Khan.
Thank you.
Okay, now.
Good afternoon. Oh, perfect. Thank you. Now you can hear me. Once again, thank you for the invitation to this beautiful city. My first time here, actually. So I've heard so much about it, but it was true. Last night, I spent the evening in the desert. It was amazing. Sitting inside the tent, it was just and I'm from Los Angeles, like a city boy, suddenly sitting in the tent in the desert. That was quite an experience. But thank you for the wonderful experience. And I remember last night, the people in the tent asked me, how do I feel about Kuwait? What is so special about it? And I told them, the first thing that hit me is not about how beautiful this place is, it's about the people. You folks are so friendly. I'm so impressed. And this is just a really amazing experience for me. So again, today we're going to talk about implant aesthetics. Now, most of you know implant aesthetics is one of the most challenging things in dentistry. Why? Because when we look at the tooth, what governs aesthetics, we need to make sure the gingiva look right, the tooth need to look right. Now, every time when I get invited to speak, in any type of meeting, I always ask myself, why do I get invited to speak? Certainly, it's not because I'm any better than any one of you out there. I'm no different than any one of you students out there because I started knowing nothing. And I tried to develop my career, trying to learn, try to do my best. And let me tell you, for every beautiful case I show you, I can show you a case that looks terrible. No matter how hard I try, because medicine is not perfect. And then another reason why I'm here is because I have some amazing students. And when I look at them, I mean, this is just a partial list, by the way. And then I list out that my friends and students, they're my friends now actually, from Kuwait here. I highlighted them in red, okay? And then from the Saudis and surrounding countries. When I look at this group of people, they are so talented. I mean, I know that most of them will be better than me. Because our job as educators is always to make the next generation better than us. That is the ultimate goal. And for those of you who are in the audience, that's in this picture here, remember, for you think it's special for you to come to Los Angeles, Loma Linda to work with us. From my standpoint, it's a privilege for me to have you work with me. So I want to thank you. And not only, I have some amazing students, right? I have a lot of amazing friends. That's why I'm here, all right? I don't know whether anybody recognizes this gentleman here. Dennis Tarnow, very dear friend of mine. Anybody recognize this gentleman here? Isfan Urban was my graduate student. He was with me in Loma Linda 20 years ago. I remember how hard he works. He always asks me, Dr. Ken, how can I become famous? Well, you became famous now. Anybody recognize this gentleman right here? Otto Shu was also with me in Loma Linda for 1 year, around almost 20 years ago. Amazing. The three of us, I mean, we're close friends. Because when we look back, we always laugh. 20 years ago, the three of us in a little city in Los Angeles, just try to work hard. No idea that we will be standing on the podium. But now we are. So for you young graduate students out there, trust me, right now you may not realize it. Decades from now, you may be standing here, much better than us. And then a lot of my friends, and we have a lot of great times over the years, all right? My dear friend Cortellini and so many of my friends. And I don't know whether anybody knows this gentleman here. John Coy's also a very dear friend. We published a lot of research together. So, you know what? When I look at myself standing on the podium, it's not about me. It's about all my friends that supported me, pushes me to get to this point. And whatever I'm about to share with you the next 3 hours, again, it's not about me because I don't remember creating anything new. Whatever I share with you is basically modified or stem from the fundamental periodontics and prosthodontics that we learned from our great teachers. Some of them still here, some of them, unfortunately, not with us anymore. So our job is actually very simple. We just take their work and keep pushing on. Hopefully, the next generation will be better than us. And thank you, ladies and gentlemen. That's why we're here today. So, implant aesthetics. Whenever we look at aesthetics, what are the issues that we're concerned about? I think this picture summarizes it all because this is a central incisor. There's an implant there. This is the facial bone. Why? Because a lot of times, regardless in the extraction socket or in the heel site, that facial bone, to a great degree, is going to define the ultimate outcome of our aesthetics. Why? Because if the bone is gone, a lot of times aesthetic will be compromised. And in an extraction socket, it's hard to predict where that piece of bone is going to rest upon. So, the next 3 hours, we'll talk about a few very important things. Implant aesthetics, immediate implant placement. How many of you have done immediate implant placement in your practice? Okay, perfect. Do they work well? We'll talk about it. And then we're going to talk about, like papillae management. And you all know how difficult it is if a papilla is missing. We call it a black triangle. How hard it is to regain it. But sometimes you hear clinicians see a patient with a black triangle, they stuff a piece of what I like to call a sashimi, that's my favorite group. Ali knows, okay? And then stuff it in there, suddenly you have a papillae. How many of you have ever tried to do surgical papillae regeneration? Does it work well? Most of the time it doesn't work. All right, we'll talk about that. Then we're going to talk about something a little bit kind of like crazy nowadays. We call them root shield. Anybody have done root shield here? Or heard about root shield? Do they work? All right. And last but not least, we'll talk about bone regeneration in the aesthetic zones. So to begin with, I'm going to share with you my first patient here. Well, we're going to talk about these 4 types of scenarios. 4 types of scenarios, 4 patients. And you see the arrow that's telling you that that tooth is failing. Patients say, I want an implant. Now, if you look at the radiograph, I specifically show you the sagittal radiograph on this tooth. You see something very interesting. Why? Remember, I told you aesthetics frequently are defined by the existence of the facial bone. But if you notice the patient on your left, this patient, the palatal bone, the facial bone is intact. Then you have this patient of mine, she's actually a prosthodontist. All right? Graduated from Loma Linda almost 20 years ago. She came to me, failing left central incisor, palatal bone is there, facial bone is missing. Then you go forward a little bit, this is all maxillofacial surgeon. He came to me, and you see with failing right central incisor, you can see palatal is intact, but the facial bone is completely gone. Last but not least, we have this patient here. Come with failing tooth, but both the buccal bone and the palatal bone is compromised. So in general, ladies and gentlemen, every time when you have a patient come to your office with a front tooth that's failing, a patient wants an implant. When you look at the bone configuration in general, they can be classified into one of these 4 classes. And today, this afternoon, I'm going to walk you through step by step what you should know, what is the thinking process. Now, last but not least, I must tell you something very important. In 2022 today, I've been practicing dentistry for over 20 years now. I learned something very important. The key to our success as a clinician is less so because of the technique we use, or maybe that instrument, fancy instrument you buy, but more so about our ability to diagnose, treatment plan, and plan the case accordingly. All right, so with that in mind, we got to look at basically this patient right here. Now, this patient, I saw her a long time ago, 1997. Some of you may not even be born yet. She came to me with a front tooth that's failing because of root resorption. Now, she said, Dr. Ken, I want an implant. Every time when the patient comes to you with a front tooth that's failing and want an implant, you can take the patient into one of 3 treatment directions. One is the classical way. You first extract the tooth, put some bone graft into the socket, call that ridge preservation. You wait for around 3 to 4 months for the socket to heal. Then you open the flap, put an implant in. Because you need to wait, we call that method delay. You need to wait. The next method you can use is you can do immediate. Now, immediate people first talk about that first published about immediate in 1989. All right? At that time, they talk about the reason for immediate is shorten treatment time. Not only that, by putting an implant into the socket right away, supposedly you can maintain the bony socket. Furthermore, if you fast forward a little bit to 10 years later, 1998, exactly 10 years later, for the first time, a publication came out saying that we can do actually immediate tooth replacement. That means not only you put an implant immediately in the socket, at the same time, you put a provisional right away. And the benefit is, supposedly with the provisional, you can maintain the gingival architecture. So you speed up treatment, maintain the bone, maintain the gingival, perfect. How many of you in the audience have ever done immediate tooth replacement? Some of you have done. So does it work? We'll talk about that. So in 1997, now by the way, there's the third path. Delay immediate, that's called the early placement path. Early placement was advocated a little bit more recently, well, still now, almost 20 years ago, by my dear friend, Danny Boozer. What Danny said is, when you extract the tooth, you do not or should not put any bone graft into the socket. Why? But by putting biomaterials in the socket, you actually are slowing down the healing process. That's what they say. And then you wait how long? Between 6 to 10 weeks. What you're waiting for, essentially, is the soft tissue to heal over the entrance of the socket. And then, after that, you open the flap and you put an implant in. That's called early implant placement. So in general, every time when a patient like this comes to your office with a front tooth that's failing, you can do delay, immediate, or early placement. Now, mind you, is that one method better than the other? In my opinion. The funny thing is, a lot of times people say, well, maybe this method is better, this method is better. For me, the way I look at the case is this. Whatever option I select or help the patient to select, I always ask myself, what is the weakness of this path? Why? Because in medicine, unfortunately, every option you take, there's always, unfortunately, some risk you need to partake. The goal is hopefully minimize that risk for the patient. So what did I do on this patient? Well, in 1997, the hot topic is immediate tooth replacement. I'm no different than any graduate students. If there's a hot topic, that's what I'm going to do. I did immediate for her, okay? And I placed the implant. This is 6 years later. What do you think about the results, ladies and gentlemen? Pretty okay, right? In fact, if you look at that implant, this implant is not even in the market anymore. They stopped selling it. It's called Jurassic Park implant, okay? But the results look good. Well, let me tell you, this patient is really dear to me. Why? Because back in, when I finished this case, immediate tooth replacement is just beginning. And when I get this results, one of my faculties told me, Joe, nobody had really published about the concept of this type of technique, and you did such a beautiful case, all right? Why don't you publish it? And trust me, back in 1997, as a young, still in my specialty training program, I have no intention to stand on the podium to speak. Porter, you don't know. I just want to finish my program, go out, open the practice, and make some money. And buy my dream car, which is a Porsche 911 Turbo. But then, because of this case, I published it. And afterwards, there are 5 implant companies approach me and say, Dr. Ken, we would like you to become a speaker. So honestly or reluctantly, because of this case, I end up standing on the podium speaking, all right? Because I really don't care too much about standing on the podium. Now, this patient, she's very unique. She's originally from India. She went to the United States to study her PhD. And, you know, when after treatment, after this 2003 appointment, she told me that, unfortunately, Dr. Ken, we need to say goodbye today. I say, why? You haven't finished your PhD yet. Well, she said, well, she met this wonderful gentleman from India, and he happens to be a really, told me a multi-millionaire, and she said, you know what, forget the PhD, just come home, marry me. So she said to choose between PhD and getting married, she just said, I'm going to get married. So she left. I haven't seen her since. But nowadays, there's this thing called social media, such as Facebook, Instagram, and in my phone, there's an app called LinkedIn. Anybody ever heard of LinkedIn? There you go. And 2013, 16 years after I treated this patient, I received a message from this patient saying, I would like to reconnect with you. When I saw that name, I say, great, because I have lectured this case everywhere in the world. This is a case that makes Joseph Ken become kind of known from nobody to somebody. I told myself, I must get this patient back to my office, take lots of beautiful pictures to show the world, reconfirm to them what a superstar I am. So I said, yes, let's get reconnected. And then after that, she dropped me an answer and said, Dr. Ken, I'm so happy I found you. I actually urgently need to see you. Now, when I see the letter, urgently, trust me, the hair on my back stood up a little bit. So I said, why so urgent? What's going on? She emailed me back, said, Dr. Ken, I must come and see you. It's hard for me to describe to you, but I must come and see you. And in fact, I'm going to have my husband's phone and email you. Now, I don't know how many of you kind of waiting for a very urgent email. That sensation, you check the inbox of your iPhone 60 times every minute. The first night that email did not show through, I did not sleep very well. The second night, the email showed up. I clicked on the attachment. Now, let me tell you, ladies and gentlemen, for those of you nowadays, because of computer is so easy, you can Google and you'll find this publication. Everybody knows the success, but they don't know the failure. I want you to ask yourself, how many of you have done the beautiful cases? You post it on Instagram, or you lecture around, show how beautiful it is, and years later, suddenly, it failed. Did that ever happen? Don't need to raise your hand. And then what do? Right away, you want to look around, nobody's looking, whip it underneath your bed. Make sure nobody sees this case again. I'm very embarrassed to show you this case. I'm not proud at all. But I also understand, ladies and gentlemen, in order for us to progress, the best way to learn is from our complications. That's why I want to share with you this case. So now, the patient say, I must come back and see you. Trust me, a lot of times after I finish treating the patient, I do not want to see them again. So this patient came back 4 months later, April 2013. And then I took some pictures. I often wonder why modern days digital camera need to have such high resolutions, you know. You can see the flash of the implant. Now, when you look at the periapical radiograph, it looks perfect. But when you look at the CT scan, there's no bone. Why? Because a lot of times when you look at the literature over the years, there have been so much heated debate. Should you or should you not even do immediate? And that's something that we need to discuss about. So what is the problem of aesthetics then? Now, regardless you're doing a veneer today, immediate implantation or delay, you can have this type of potential issues. Recession, discoloration, or when you look at the tooth incisally, you can see the facial gingival collapses down. Now, all three of these factors have a propensity to go hand in hand with each other. In other words, is one of them have a problem, a lot of times it ties in with the other two. So in 2023, today, in Kuwait, let's look at what can we even minimize this type of aesthetic problems. And in order to really evaluate how to minimize these problems, I want you to look at a patient. Remember, I show you 4 patients. This is the first patient on your left, all right? She's a fashion model, failing right central incisor because of root resorption. Now, I want to make sure you understand, if a patient comes to the office with a front tooth that's failing, our goal as a clinician is to maintain whatever the patient has and do not make it any worse. How do we maintain? Well, let me tell you. For the first time today, we would like to define the gingival architecture, actually the facial aspect of the tooth, into 2 zones. First, I like to call it the hard tissue zone. That means where the bone is. How do you know where the bone is? Because we know, as a clinician, regardless you're a prosthodontist, general dentist, or periodontist, we know from the gingival margin, initially, this area here, there's no bone. We call that the dental gingival complex. Now, when you go down further, you find the crest of the bone. That's why from the crest of the bone apically, I would like to call it the hard tissue zone. Now, one of the reasons I want to define is what methods do we have to maintain the hard tissue zone? We know now, if we do to maintain the hard tissue zone after immediate implant placement, we got to put bone graft in there. In some situation, another concept is we need to do what you call contour grafting. Either contour grafting with bone or soft tissue, or a combination of bone and soft tissue grafting. What are the concepts we have more recently? 12 years ago, Marcus Herser and Otto Schuh told us about maybe you can leave a sliver of root, they call that root shield, to full nature as if the tooth haven't been extracted, and therefore maintaining that facial bone. So in 2022 today, these are the materials and methods that we can use to maintain the hard tissue zone or attempt to maintain the hard tissue zone. Likewise, I also told you, we have the soft tissue zone. How do we maintain the soft tissue zone? That means soft tissue zone is the area from the gingival margin to the bony crest, this area, the soft tissue zone. Well, what we know in 2020 today is there are basically 3 methods. One, most clinicians just leave it alone. Don't do anything. Or you can do what you call a scarf connected tissue graft. Scarf is like, the scarf you're wearing on your neck. And then rather than you put that tissue right at the soft tissue zone, above the hard tissue zone, between the gingival margin to the hard tissue zone there, like a scarf around the entrance of the socket. Or my dear friend from New York, Stephen Chu and Dennis Tanao call, maybe you can just put bone graft in there. They call it the dual zone technique. So ladies and gentlemen, to maintain the hard tissue and the soft tissue zone, there are these methods you have on your disposal. We will walk you through what works, maybe what doesn't work. How about that? All right, so now, going back, this is to our patient, our fashion model. You can see a failing tooth. This is a checklist I'm going to provide to you. Because in my practice, every time I always look at this checklist to walk myself through, how can I manage the aesthetics? First of all, thickness. What we mean by thickness is the thickness of the gingiva. We call that the phenotype now. Phenotype. How do you assess phenotype? Well, there are many methods. Obviously, the best method is to do direct measurement. But it is traumatic. Therefore, nowadays in periodontology, the method that we accept probably the most is use the periodontal probe. How so? We put the sulcus, then we lift the probe towards us facially. If you can see the outline of the probe shining through underneath the gingiva, we tell ourselves the patient's phenotype is on the thinner side. All right? Now, what is so bad about thin phenotype? Because we know now, when tissue is thin, it increases of risk of recession, increase of risk of discoloration, and so forth. Now, we also will talk about if the phenotype is thin, if you put a piece of, I like to call it sashimi underneath the tissue, aka connective tissue graft, will that thicken the tissue? Will that minimize recession? We'll talk about that. But anyways, that's the thickness. That's the first thing I evaluate. Now, the second thing I look at is the bone. Where is the bone? Because we know underneath the facial aspect of the tooth, if I open the flap, we can expect to see a layer of bone there. Now, before surgery, the best is, without raising the flap, how can we estimate where the bone is? We first anesthetize the patient, take our periodontal probe, lean the probe against the root, and push until the probe stops advancing. Hopefully, what prevents the probe from advancing is the bone underneath there. In other words, bone sounding, in periodontology, we used to call them, transgingival probing, in which without raising the flap, you can estimate where is the bony crest. Now, why is that important? Because a friend of mine, Maurice Henry Salama and David Garber, make this statement once. He said, the bone sets the tone. That means in order to have soft tissue, you must have bone underneath there to support it. I'm sure some of you heard about it. To be honest, in the year 2022 today, that statement is not true anymore. Why? Especially on the facial aspect of the tooth, the facial aspect. The bone often is not needed to set the tone for the facial gingiva. Then you say, what do you mean? Well, this is what Joe is trying to tell you. How many of you, if you have braces before, braces, orthodontics, when you look in the mirror, lift your lip up, you have no recession. But if you allow me to numb up your gums and open up the flap and take a picture, some of you may not be very happy. Why? Because a lot of times after also, what happens to buccal bone? Some of the time, buccal bone is not there, but yet no recession. Therefore, a lot of times, the buccal bone is not absolutely needed for the facial recession. However, we would still ideally like to see that presence of the buccal bone. So we do bone sounding to see where's that underlying bone there, all right? Why? Because we know what normal is. We want to follow to this classical article published in Journal of Periodontology by 3 persons. Gargiulo, Wentz, and Orban. Orban knife, remember? There you go. on a dead human beings, they took out the jaw. They do histology, looking at the tooth, the area between three gingival margin to the underlying bone. Now, I magnified it. You all remember that. Even as a dental student, histological, you have first of the sulcus. You go deeper, you have the junction epithelium. Then you go deeper, you have the connect tissue attachment. But the key point I want to bring home for you is this. Based on this study, if a patient have no periodontal disease, and the tooth have been erupted normally, they realize that each one of these components has an average dimension. And if you look at it, each one, the average dimension is approximately 1 millimeter. In other words, on the facial aspect of a patient's tooth, and providing, if that patient have no periodontal disease and no eruptive issues, the average distance between the pre-gingival margin to the underlying bone is 1 + 1 + 1 equals to 3. So that is a key magic number that we as surgeons and as restorative dentists always want to seek for, because that stability, right? Now, we just go and talk about right here, going back to our patients who's a fashion model. When you look at this patient, from a degree of complexity standpoint, remember patient came in with a front tooth that's failing? From a degree of complexity in terms of aesthetics, do you think this will be an easy or difficult case? How many say difficult? I agree. Why? High smile line, thin gingiva, but one thing I want to show you that haven't been published in the literature yet is you want to look at the patient from incisally like this and look at the gingival profile. When you analyze the patient's gingival profile like that, you can broadly classify them into one of two types. One is the gingival profile is nice and flat. The other one, like our patient, scallopy. Each one of these two methods tends to be more challenging from an aesthetic standpoint. What do you think? How many say the scallop one? And you're absolutely right, Kuwait. You're absolutely right. Why? Because maintain a scallop bony architecture is challenging. Why? Because the tooth tend to be more pronounced on the bony socket there. And then after you extract the tooth, it is very difficult to maintain anything that's in a curve, despite bone grafting. And in fact, when you do bone grafting, a lot of times after healing, the bone likes to be flattened. They do not like to heal in a curvature. Because of that, this patient is very challenging. I'm going to walk you through what goes through in Joe's mind. All right? First of all, diagnosis. We always take a periapical radiograph first. What do we look for? We know now. Seriously. We see the outline of the root. Ideally, what we like to see is at least 4 to 5 millimeters of bone apical to the root tip for the engagement of the implant. Because why? Because we know now when we do immediate implant placement, stability of that implant is of paramount importance. And if the bone is cannot get stability, so rule number 1, apical to the root tip, at least 4 to 5 millimeter bone. Rule number 2, this is to be published material. And for the first time, because clinicians always say, when I evaluate a case, I always take a PA, I always take a CBCT. But this is actually even more important. Why? This group of authors, with my dear friend Giovanni Zucchelli, we decided to publish articles telling the people that when you evaluate aesthetics, you must take an axial view. Axial view. So you can see a cross-section of the tooth axially. And you can see the patients, the pronounced root. That's why the scallop architecture. But the key thing is they find out from a sequential study that when the more pronounced the root, you see the red line here, the more pronounced the root, the higher the propensity that after healing, implant placement, and bone grafting, that arch bone tends to flatten out to that red line connecting the two interproximal bone there. So what you need to bring home is CBCT scan axial view is also very important for your diagnosis, because in this application, the author suggests different type of method of treating the case depending on how prominent is the root to the architecture based on the axial view. Then Of course, we talk about bone sounding. Last but not least, we must look at the CBCT scan. Now, what do you look for the CBCT scan? Most people say, I want to look at how thick is the buccal bone. Well, how effective, may I ask you, is using CBCT scan to evaluate the presence or absence of buccal bone? How effective is it? What do you think? How many say not effective? Effective. Most of the time, it's not very effective. Why? Because we know now, if the facial bone is on the thinner side, anything less than 1 millimeter, a lot of times you don't see it on the scan. Now, how many of you have do an evaluation on buccal bone on the CBC scan? You say, there's no buccal bone. But when you do surgery, you open the flap, there is buccal bone. How many of you have experienced that? Look at the room. Most of you have experienced that. That's why CBC scan, the purpose for me looking at it is not really the presence or absence of buccal bone. I used to do bone sounding to evaluate that. What I look for is how I plan for the implant. Now, I want to ask you, if a patient comes to your office needing an implant, what methods do you use to evaluate the dimension of that implant? That means what diameter, what length of the implant. Now, whatever method you use, I'm going to tell you, whatever I'm about to show you is probably different. Why? Let me show you this. This is how I do it. First, I took a CBCT scan, and then I want to look at the buccolingual dimension of the socket, the buccolingual dimension of the socket, where at the bony crest, it's a 6.75 millimeters. Now, I want to make sure you understand the little details here. Sometimes you cannot see the presence of the buccal bone, but you can see the CEJ, right? You can see the CEJ. To be published articles show on CBC can show that the CEJ tends to be roughly 1.5 millimeters apical to the CJ. That means the bone is 1.5 millimeter apical to the CJ, providing that patient has no periodontal disease. Now, why do we measure at bone level? The reason is when we place implant, typically that's where we place the platform of the implant, or sometimes we place the implant platform 1 millimeter deeper than that. That is why we use that line to define what size implant we use. Now, let's make sure you understand this in detail, okay? When you look at the buccolingual dimension, are you measuring from the outside of the bone to the outside of the bone, or from the inside of the socket to the inside of the socket? What do you think? How important it is? Very important. Let me tell you, the key measurement is you measure from the inside of the bone to the inside of the bone, not the outside to the outside. All right? Because just imagine, if you have a ridge this big, then you say, no problems, I can put the biggest implant in there. But you know what? No matter how wide the ridge is, what defines the size of the implant? It's a tooth. Let's say this is a sagittal rib, the ridge is this big, but the tooth buccolingual is this big, this wide. The ridge is this big. Are you going to put an implant like this? No, you got to put the implant within the tooth. Therefore, if the tooth is in the right position in which this patient is, first step, we measure the inside of the socket, inside to inside, 6.7. What's the next thing? The next thing is, if I'm going to put an implant in there, what size should I do? Well, we know now from the literature, ideally, we should leave a distance of 2 millimeters from the inside of the socket, in 2 millimeters. Minimally 1.5, ideally 2. Then, does that mean this is how you define the implant diameter? No, not yet. You must tell yourself, I must leave a space of 1 millimeter from the palatal bone to the implant of 1 millimeter. Why? Because you see a lot of times surgeons try to put the implant as palatal as possible. The problem is not the surgery, the problem is aesthetics. A lot of times if the implant is too palatal, what happens? You need to over-contour the lingual palatal or lingual aspect of the crown restoration. Now, with patients deep bite, that becomes a little bit more challenging. Therefore, if you go like that, 6.75 minus 3, You get a number, but you also realize whatever numbers you get, you need to select that implant with a diameter that's 1 step smaller. Why? Because you need to allow for room, wiggle room for errors. Because of that, in this situation, I decided to put a 3.75 diameter in there. Now, next thing is, how should you position the implant sagittarily? In my humble opinion, there are 3 positions that I position the implant sagittarily. Either aim it at the cingulum to make it screw retain, or aim it at the incisal edge, or to make it cement retain, or aim it facial to the incisal edge. That's my only 3 positions I aim for. I don't try to aim in between cingulum, incisal edge, or facial. That's simple. Now, why is that important? Because once I assess this is what I look for. You see that all 3 positions, the pivoting point is the middle of the implant. The pivoting point. And what I look for to determine which direction I go is by 2 things. Number 1, whichever path I go, will the implant be surrounded by bone? Number 1 rule. Number 2 rule is, whichever path I go, how much tooth I have and how much remaining bone I have. Understand? Because for immediate implant placement, the shorter the tooth structure, the more the native bone, the better to the equation. Make sense? So, when you look at this, what do you think? Is cingulum good? Yes or no? No, because you probably perforate the bone, forget it. How about incisal edge? Well, compare incisal edge to facial. Facial have the least amount of tooth, the longest amount of bone. So in this situation, I tell myself, Joe, the best scenario is to go facial, right? All right. So now, what's the next step? When I go facial, I look at how much bone do I have remaining, 17 millimeters. Then you ask yourself, what implant system are you using? Because different implant systems have different length, right? Let's say if you use Straumann, they're even numbers. You use something like Nobel Biocare, they're odd numbers. What is the goal then? You look at, this is the tooth structure I have, around 7 millimeters, and I'm going to use a 15 millimeter diameter implant in there, right? And if I put a 15 millimeter diameter implant, that means half of my implant will be engaging bone. Now, why is this significant? It's significant because, one, to be published study. What we did is this. We look at when clinicians do immediate implant placement and provisionalization, the percentage of implant being engaged to the native bone during surgery, does that affect implant success? Interestingly enough, yes. Why? Because obviously, the less the implant being engaged to the bone, when you do immediate tooth replacement, the higher the risk. This is the demarcation line. What is it? 30%. In general, if you do immediate implant placement and tooth replacement, if your implants are engaged in less than 30% of the native bone, the risk of implant failure is going to be significantly higher. So my goal is always to make sure that I'm going to, when I plan the case, there's more than 30% of the implant being engaged in there. And this, ladies and gentlemen, is how I select the implant. All right? Dimension. So with that in mind, when you look at it here, how should you position the implant? Well, very simply, first of all, apical coronally. How deep? Typically, wherever the gingival margin is, we put it 3 to 4 millimeters deep. The key is the gingival margin, not any gingival margin. Why? Because before you place the implant in, you look at the case. Is my gingival margin where I want it to be? If in this situation, you can see the gingival margin is a little bit more coronally position of the adjacent tooth, that means I need to compensate. That means my ideal gingival margin is probably here. From that point on, I will move the implant 3 to 4 millimeters deeper. How about incisally? I first draw a line bisecting the tooth in half, that's right next by it. The middle of the implant should be 1 to 2 millimeters more palatal to it. There's one more point we must know. We also want to draw a line connecting the facial aspect of the 2 adjacent teeth like that. Why? Because after placement, the facial aspect of the implant need to be roughly or minimally 1 millimeter parallel to that line there. Last but not least, sagittal implant position. In my humble opinion, the most powerful and optimal position is the incisal position. We talk about cingulum, incisal, and facial. The most powerful is the incisal. Then you say, why, Joe? I'm going to explain to you in just a minute here, all right? So, again, to get stability, you got to engage the bone 4 to 5 millimeter apical to the root. And sagittal, you want to take a CBC scan, and ideally is to engage the bone that's parallel to the root, something like that. All right? That's the ideal configuration. Now, fortunately, not every case you can do, to put the implant parallel to the root. Why? Because this CBC study published by this group of researchers in 2011 tried to tell us that when you look at maxillary anterior teeth, the way the anterior root interacts with the premaxillary bony housing can be broadly classified into one of 4 classes. One, in which the root is tilting facially, literally touching the face. Then you have class 2, in which the root is situated right in the middle of the bony housing. Now, that's class 3. You'll notice the root is actually tilted parallelly, touching the palatal bone. Last but not least, we have class 4, in which the buccolingual dimension of the root is actually greater than the buccolingual dimension of the bony housing. Now, let me ask you, ladies and gentlemen, if you were doing immediate implant placement, which one of these 4 classes do you think is the best? Class 1, 2, 3, 4. But let me tell you, if you are a surgeon, I guarantee you that 100% of the time, your restorative dentist prefer you to put an implant in a class 3 situation. Why? Because I believe nowadays, all restorative dentists want to restore the case in a screw retain position. Now, unfortunately, if you are the surgeon, when you need to put an implant in the patient's anterior teeth, most of the time you end up placing the implant in a class 1 situation, which renders it cement retain. Then you say, why, Joe? Because based on this study, when they look at how often each one of these classes presented in our patient population, they found something extremely interesting. Majority of them, 81%, belong to what? The class 1 group. How often do we see class 3? 1%. Therefore, most surgeons end up placing the implant in a cement retain group. Now, then you say, are you sure? I am very sure. Why? Because we look at this group of authors did this publication last year, 2011, in a Journal of Maxillofacial Implants. What the authors did, and then I need to thank my dear friend Alex Lin, who's a Japan director in UCSF, and then my also dear friend from Italy, Giovanni Zucchelli. So what the authors did is, on this researcher is a CBCT scan study. On 200 patient scans, they isolated the sagittal cut of these 200 patients, maxillary canine to canine. That means you have 1,200 sagittal cut view. After that, they utilized a digital planning software. In this situation specifically, they call that the DTX Studio, to simulate a taper implant into the socket to see how often you can put an implant in a screw retain position immediately. There are 2 rules they abide. Rule number 1, however you position the implant, there must be at least 1 millimeter bone surrounding that implant. That means no perforation. However you position the implant, at least 30% or more of the implant will be engaged in native bone. Got it? That's the 2 rules. So if you look at the patient on the left here, you can do screw retain, no problems. However, when you look at the patient on the right here, it's impossible to do screw retain unless you perforate the bone, right? So they want to look at how often on that 1,200 sample size can they get, like the screw retain. Now, none of these patients have periodontal disease, guided bone regeneration, or guided tissue regeneration. All right? So this is the data right here. They look at centrals, laterals, and canine with different diameter. Look at this column here. This is how often, based on this study, they can achieve screw retain position. If you look at these numbers, a little bit depressing. Why? At best, probably around 15%. Therefore, it once again reconfirmed. It's challenging to do an implant immediately into a socket and make a screw. Nowadays, most implant companies have this capability that they create what you call an angle channel abutment. In a sense, for example, patients like this here, implants can only be placed in a cement retain position. What happens if your implant company can create a restoration in which you can change the angle of the restoration up to 25 degree or 30 degree to make the screws non-screw retained implant position into screw retained? What will happen? If you do the ASC, how many of this non-screw retained implant position became screw retained? This became part 2 of the study to be published. Again, what this group of authors look at is, if you add the ASC in the equations, what happened? Now, the first 4 columns, you've seen it already from the last publication. I want you to look at this column with the angle channel abutment. Suddenly, it changes from only 10-15% of the implants from screw retain to close to 80%. Now, ASC is very powerful. How many of you have used angle channel abutment before? You must use it. It is amazing. But then, you know what? If you look at this number, I have one of those emoji moments. I look at it and say, why? How come it's not 100%? Shouldn't it be 100%? Why is it only 80%? Then I ask myself, why? In order to answer this question, I'm going to show you this to be published material, work with another very talented graduate student of mine from Thailand. And what the authors look at is this. What are the different variable factors that affect you as a restorative dentist or you as a surgeon capability to create what you call, to restore the case effectively with an angle channel abutment? All right, let's take a look here. I simulated 4 crowns here. They're all the same shape, same length. You see the vertical line that is pointing at the incisal edge. Got it? Now, what you need to know is this. The first question we ask ourselves is, if we need to bend the angle back like this, how far can we bend the angle and make the screw retain crown effective? Let me make sure you understand. If the screw channel is like this, okay, aiming somewhere, I don't know where you can see it, right here. You can still use a screw retain crown, but usually what happens? You do not want to resort a screw retain crown because if the channel aim right here, the hole is right here, you'll notice that the porcelain at the incisal edge gets really thin. I'm sure some of you have experienced that. And you know the chance of an impending fracture of that porcelain is going to be very high. Therefore, under such circumstances, most clinicians say, or the lab technician will tell you, let's do cement retain. Forget the screw retain, right? So the question on this study, first of all, is how far do you need to bend the angle back in order minimally, yet still have enough porcelain structure for you to maintain the integrity of the crown? When we look at that, we found the answer is 10 degrees. In other words, as a restorative dentist, the minimally you should bend back is 10 degrees from the incisal edge. That means anything less than, means if you bend it back 8 degrees, you will weaken the incisal edge of the porcelain of the crown. 10 is absolute, the minimum. Now, of course, if you can go 15, better, 20, better. But 10 is minimal. But what is Joe's point? This is my point. If minimally you can bend back is 10, how far can you push back facially then? Well, That means, as a surgeon, if you want your restorative dentist, despite the fact that when you put an implant, it needs to be in a cement retained position, but you want your restorative dentist to restore the with angle channel abutment effectively. In other words, as a surgeon, you must never place an implant and tilt it facially more than 15 degrees. Am I making sense? All right. But then you say, you know what, Joe? This is so subjective, arbitrary, okay? 15 degree, how do I know where's 15 degree? I'm going to define it for you. So from now on, if you are a periodontist, you will know exactly where to go. There's no doubts, no buts, no ifs. Why? Because when we do the measurements, we find something interesting. 5 degree, 15 degree, 20, this is maximum you can tilt. But not only tilting 20 degree, we measure. If we tilt 15 degree, how far a distance we have from the incisal edge to the exit of the hole. We notice that 3 millimeters. In other words, if your surgeon, when they place that implant and tilt it facially, and the implant needs to be tilted more than 3 millimeters from the incisal edge facially, the chance of your restorative dentist ending up using the ASC is probably 0. You understand? Now, let me make sure you guys understand how it works. This is what I do. You extract the, okay? Then you use the pilot drill, the first drill, all right, into a socket. After you finish drilling, you leave that drill in the socket, leave it in. And then now, let's say this is the right central incisor, you look at the left central incisor, and then what I do is this. I look at the incisal edge of the left central incisor, and I take a periodontal probe, aligning it to the incisal edge. And this is the pilot drill, this pilot drill. Then next thing is I take a probe measuring from the incisal edge up to see how far this angle of the pilot drill is angled out. If after the pilot drill the measurement is greater than 3, then I better change it. Because your restorative dentist or prosthodontist, the chance of them using ASC is probably 0. Understand? Not only that, in this interesting to be published article, they look at the variables. What are the variables? They look at 3 variables. All right, this 3 millimeter rule. Does the width of the crown, that means some patients the crown is wider buccolingually, some are narrower. Does that play a role in affect this 3 millimeter rule? Or does the length of the crown affect this 3 millimeter rule? Or does how deep the surgeon places an implant, will that affect your 3 millimeter rule? Let me walk you through. So you have no doubt, 100% sure. First of all, crown width. Look at the 3 crown. Narrow, normal width, wider. What did they find out? Insignificant. That means how wide the tooth is has no bearing factor on that 3 millimeter rule. It still works. Then how about the length of the crown? Average length of maxillary central incisors, 10.2, 10.5 to 11.2. That is normal. What happens if the crown is shorter? What happens if the crown is longer? The length of the crown do play a role affecting this 3 millimeter rule. How does it affect? This is how it affects. The shorter the crown, the more sensitive that 3 millimeter rule is. That means the shorter the clinical crown, you can only tilt it less than 3. You understand? The longer the crown you can tilt it, you have more room to tilt. Make sense there? All right. So how do you do it? Before the surgery, you measure the clinical crown length of the tooth you're about to replace. If it's normal length, follow 3 millimeter rule. If it's shorter than normal length, what do? You say, as facially, otherwise I not use the angle channel abutment. All right? How about the implant depth? Again, different depth here. This is what we find out. The deeper you put the implant, just like lengthening the crown, the 3 millimeter rule applies. In other words, if you as a surgeon is going to replace a central incisor that is short, and then also when you place the implant, you place it shallow, you will not be able to change the angle. Even if you change the angle, it will not be still retained. So, crown length and implant depth is the sensitive things that you must understand. Now, I believe once you understand this concept, There's absolutely no reason your periodontist put an implant in and you say, I cannot use the angle channel abutment. Absolutely no reason. Understand? All right, so with that in mind, let's look at this patient here. Patient has a failing left central incisors. The surgeon basically put an implant in, and 5 days later came to my office and said something is loose. I take a look at it, the whole implant came out. What is wrong with this equation? Why? And people always say, you know what? If an implant fell, a lot of clinicians in the United States will say, oh, the implant's no good. There's a bad implant system. I'll never use it, or something's wrong. To be honest, I always tell my graduate student, if you did a case and the case went wrong, to find out the cause of the reason of the failure, you need to do one very simple thing. You walk straight to the bathroom, close the door, turn on the light, look in the mirror, you will find the answer. Most of the time. At least that's how it works for me. So what's wrong with this case here? I want you to take a look here. All right? Implant came out 5 days after immediate tooth replacement. This is the periapical radiograph here. You can see rule number one, if you see the root tip to, that is the base of the nose right here. 1.8 millimeters, good or bad? Good or bad? Not good. How much bone are you supposed to have? 4 to 5 millimeters. So when you start violating the rule, and not only that, when the surgeon put the implant in there, how much of that implant is engaged to the bone? Less than 1 millimeter. See, when you're pushing the envelope, let me tell you, in medicine, whatever procedure we do, there's always a potential risk. I always like to call treatment planning is a risk management. It's whether you can minimize the risk. Every procedure has a risk. It doesn't matter what you do. Don't think implant is that magic bullet that will last forever. It will not. I have seen too many of my implants fail too. All right? So because of that, how about sagittally? This is what you notice sagittally. This is a sagittal root position 1. Where should the surgeon engage the bone? Palatally, right? Where did this surgeon engage the bone? Palatally. Then you say, good, this is great, Joe, but not good. Why not? What percentage of this implant do you think is engaged to the bone? What do you think? Is it 30%? What do you think? Less than 30%. Therefore, you increase the risk. This is something that, we are understanding how things work better and better now. So with that in mind, let me take you to one step further here. You look at these two patients. Question is, are this patient good for immediate implant placement? What do you think? What do you think? Yes or no? You look at the root, that's a lot of bone apically. Good. Then you look at a CBCT scan, this is what you see. So you usually align the dots, you move the blue line to where you want to look at the tooth, you get a cut. Is this patient good to do immediate implant placement? What do you think? How many say no? I agree. Why not? Because what is this? What is this? First of all, there's not enough bone. What is that right there? Incisive canal. Is it good to just no bone, push the implant in the incisive canal? You're just waiting for a mistake, a failure to occur. Now, let me ask you something. A lot of times, when we do CBCT scans, doesn't matter what machine you use, this is the rule we follow. We use the blue dots to follow the curvature of the arch, and then we move the cursor to the tooth you want to look at, and you get a cut, right? But let me ask you, let's use this patient as an example. Look at the blue line, the straight blue line. If you are the surgeon, will you do the implant surgery according to that blue line? What I'm trying to tell you is this. If you do surgery according to the blue line, that means the more buccal you put the, I'm sorry.
Sorry, the voice is not very clear on the recording, so we'll just change the microphone.
Please change the microphone, please. Okay? So, The question is, if you follow the blue line, does that mean the more buccal you put the implant, the more lateral you put the implant? Vice versa. The more palatal you put the implant, the more medial you put the implant? Why? Because if you look at this line, you'll notice that the blue line, that is, the outside of the blue line is more lateral, the inside of the blue line is more medial, right? So will you place the implant according to that? What do you think? What do you think? Will you? You won't. The way, how would you position the implant? The more buccal you place the implant, you should be straight up and down, right? Straight up and down. So what is the story there? How many of you have planned a CBCT study? I mean, evaluate case using CBCT. And then, after you plan everything, you basically go to the surgery, open the flap, you find out that how come what I see in the patient's mouth is different from my planning? Anybody have that happen? There you go. Then you say, why? Then you say, oh, maybe patient's head moved, maybe something's not right. Well, very simple. Let me tell you, it has to do with the way you diagnose your CBCT scan. Why? Because this is what everybody taught you, because you use a blue dot following the arch. We call that following the curvature of the arch. But I'm going to tell you that the blue line position is wrong. How can you correct the blue line position? You do this method, the straight method. That means you position the blue dot horizontally at the anterior plane, horizontally like that. Now you see that the blue line is straight up and down, right? Then you say, what is the point? This is the point, ladies and gentlemen. Look at the top patient. This is the same patient. I change it. This is what I see. Now, if you look at this right here, I think most of you will tell me that, Joe, I think this patient, we can do immediate implant placement. No problems. But this is the same patient that you just told me you cannot. Why is that? Because anytime when there's a curvature in the arch, the way you cut, the cut becomes misleading. It doesn't matter what type of software you use. You can use a blue sky, whatever. You just make the line straight, and you get a very clean cut now. You don't need to do it to a posterior tip because posterior is in a straight line. Anterior tip is in a curvature. So you only need to evaluate that doing the centrals and the laterals, not the posterior tip. Because by doing so, you will be able to see that in this situation, you don't see the nerve anymore. Why? Because now you're straight up and down. This is going to work. I mean, you go home tomorrow, you check, and you say, wow, I see a difference. And it's going to change the way you plan your case. All right, so with that in mind, okay, this was published in this journal by this group of authors in 2012. And basically, if you want to read about it, that's where you want to read about it, okay? All right, so with that in mind, when you look at an extraction socket, this is the ideal equation here. That means after you place the implant, you want to leave a gap between implant and the buccal bone. Minimally 1.5, ideally 2. And you all want to leave a gap between the implant and the palatal bone there. That's the ideal there. All right, going back to our Hollywood movie star. How should we treat this patient there? High smile line. We learn something. We say, all right, remember, sagittally, we need to place the implant facially. No choice, because of the bone configuration. We also know that this patient, have thin phenotype, because we can see the probe shining through. So we may need to consider about doing like a sashimi graft in there to thicken up the gingiva, to make the gingiva more resilient. What else did we learn? We also learned that, all right, this patient, because it's scalloped, and the axial of the CBC scan is more pronounced, under such circumstances, we know the chance of the ridge collapsing, creating an aesthetic issue is high. So what we now propose is when we see patients like that, we must also graft outside the socket to compensate for that collapse, you understand? All right, last but not least, thin phenotype high smile line. Now, this is the type of patients that if I don't need to raise a full flap, I'm not going to raise a full flap. Let me make sure you understand, my dear friend from Kuwait. I'm a firm believer that it's better to raise a flap most of the time. I notice a lot of my young graduate students, they say, I want to do flapless surgery. To be honest, if you want to train yourself to be a fantastic periodontist, do not start by doing flapless surgery because that's doing you a disservice. You cannot be that wonderful periodontist and understand soft tissue management until you raise and close the flap at least 5,000 times. You will not understand what's tissue management. Flapless surgery is not tissue management. Yeah, it's kind of cool, but you will not understand how to control the tissue. You understand? So if you're a young student, I challenge you, just go ahead, raise the flap. Doesn't matter how your faculty is going to tell you. You must learn. If you don't learn, you cannot suddenly be magical. It doesn't work like that. All right? Then on top, frequently, Mo's my dear friend and my former student, we're friends, okay? I always say, a lot of times the difference between raising a flap and not raising the flap is probably what? 6 months. 6 months later, it looks almost the same. 6 months later, it looks almost the same. All right, so now, I know that in this situation, patient, high smile line, thin phenotype, I try to do flapless surgery. And I also know that I need to aim the implant inside, facial to incisal edge. Unfortunately, at that time, we do not, have the so-called, the ASC yet. Actually, ASC just barely came out. All right? Then I also know that the problem is if I don't raise the flap, how am I going to graft outside? Because the contour of this tube is very, pronounced. How do I do that? So the hard tissue zone, remember we always graft the gap, and when we want to do the contour graft in this situation. And then in this situation, I'm not going to do root shield because I don't always do root shield. At that time I did this patient, I only have like 2 years of experience with root shield. On a Hollywood movie star, I'm not going to go ahead and just say, let's do a root shield, because if it fails, she's going to hate me, right? So, and in this situation, the soft tissue zone, I'm going to do the scar tissue graft here. That's the plan, all right? So how do we execute it? That's the patient. Extract the tooth. This is a root tip socket because it's tilting facially. It's a class 1 sagittal, right? You don't want to follow the root tip. You want to start the ostomy palatal to root tip. You see that? And then you want to leave minimally 1.5 facially and 1 palatally. You graft the gap. Now, let me address something important. When you graft a gap, what type of graft material should you use? Okay. 3 points I want you to make sure you understand how to graft a gap. Point number 1, if you use biomaterials, xenograft versus allograft, which one is better? We did a study, in the midst of the study, using scanning and geometric to compare the tissue collapses, comparing grafting the gap with xeno versus allograft. Guess which one collapsed more? Allograft. You're perfectly correct. So I use small particle xenograft. Question number 2, when you put bone graft into the gap there, how should you pack the graft into the gap? Do you just gently put something in there, or do you push? When you do grafting, do you just gently put the graft there, or do you put pressure to push the graft? What do you do? How many gently push it in? How many push really hard? So, years ago, decades ago, I remember my friend Frank Spears would tell me, Joe, if you put bone graft, you should gently put it in. You know why? Because if you pack it in, you're going to devoid the spaces between the graft, compromise the way the blood can get into the graft. But nowadays, in 2022, that concept is totally changed. We realize histologically, when we compare gently pushing the graft, different pressure, more pressure with a lot of pressure on the graft, and later on when we do histology, you know what we find out? The more pressure you put, not crazy pressure, the more pressure you put in there, actually you get better bone regeneration. Not only that, you can maintain the contour better. So now we want to put some pressure, not just gently put it in. If you gently put it in, it may not maintain the contour so well, right? Number 3, then you say, Joe, when I graft the gap, when I put the xenograft in there, is it okay for me to mix some of the bone that I collected from the drill, and then mix it in there? Will that work good? Let me tell you, a friend of mine who worked with Danny Buser, Myron's article they compare different methodology to harvest autologous bone, using tree fine, using piezo, using bone scraper, using the drill to collect the bone. And what they did is they look at histologically the osteogenic potential for each one of these graft that's harvested by different methods. They find out that the bone that's collected from the drill has the weakest osteogenic, almost nothing. The best is you refine the bone and you mill it or using the bone scraper. All right, so that's the 3 things. So always graft the gap. And then how do I graft them? Remember, I'm going to use flapless procedure. I did the immediate implant placement already, right here. I just make sure I engage plenty of implant here into the bone. Make the provisional screw retain. And then I make a little slit right there. A slit. This is almost like pain tribulation to my dear friend. I hope he's here. I don't even know where he left yet. He's still here. He's probably in the desert. I bet you he's in the desert. Like me, he's in the desert, looking for another camel to ride, I'm sure. So Homer Sadat is a dear friend of mine, a really dear friend. Okay? I just was with him a week or so ago in his practice. We were just talking about doing some lectures together. So it's almost like a pseudo-vestibular incision. And then I do a full thickness tunneling, and I put bone graft in there. Then you see the sashimi, the little sashimi right there, my favorite fruit group, just right there. And so how does it work? Well, let me show you. This is the same patient. After implant placement, I'm going to pack the gap with xenograft, ideally. Okay? Graft the gap with xenograft, small particle, pack it in. Then, through the slit incision, I'm going to do a contour grafting from top. All right? Contour bone graft. Again, xenograft. I use the periosteum, which is still majority intact, as a barrier, so I don't put a resorbable membrane in there. Then the next step is the provisional. You want to make sure you under contour the facial aspect of the provisional. One of the main reasons is for the reception of the scarf connective tissue graft. All right? And if needed, we'll do a cross-link suture right at the entrance just to hold the tissue graft there. All right? So, scarf connective tissue graft. This paper will be published in this journal this coming year with my dear friend Giovanni Zucchelli and Istvan Urban and other teammates. And what they do is a study looking at the effectiveness of the scarf connective tissue graft. All right? The scarf connective tissue graft. How that means, after the implant placement, graft the gap and put the tissue graft spanning from interproximal to interproximal. And then utilize the provisional to hold it in. And what I did this picture is this. I put the provisional in, and then I removed the provisionals like 10 minutes later, just to show you the graft had been pushed and molded into the position of the soft tissue zone. Right? And how does that work? So based on this study here, The mean follow-up time is 8 years. Using the scarf connected tissue graft, the mean tissue change is 0.19 millimeters. So it can maintain the tissue graft, maintain the gingival margin quite well. And not only that, when the authors measure the facial tissue thickness at baseline, to follow up, it gains around 1.5 millimeters. So, in a sense, using a scarf connected tissue graft can effectively thicken up that tissue graft there, and so forth. So going back to our patient, you can see with the provisional, you can see, the hole right there. But as a provisional, I don't really care. We could change it with the definitive restorations anyways. So how about healing? All right, remember the scarf, the bone graft, the scarf connected tissue graft. This 18 months later, you can thicken up the tissue graft. So this is an 8-year follow-up, but I want you to look at this. Can you see a scar? Can you see that scar right there? Can you see that scar? Right up here? You can also see a little divot right here. You see that? That's where I make the incision. Just imagine on this patient, if I make the incision all the way down to the gingival margin, right? So this is a 11-year follow-up, okay? So yes? Okay, perfect, thank you. So how about dual zone? Dual zone is advocated by my dear friend Stephen Chu, such as, for example, this patient of mine, failing to just keep the story short, how dual zone work is this? I first pack the gap with xenograft, then I pack the area above the implant platform to the gingiva with allograft. You can see the healing there. And in fact, if you look at this patient, I intentionally take this picture just to show you. When you put bone graft there, even with allograft, can you see some allograft particles still? Can you see some bone graft material? It's just, sometimes they just stay there. It doesn't resorb 100%. And that is sometimes a problem, okay? Why? Because, well, this is a 3-year result of the same patient, but I want to show you this patient. The funny thing is, my dear friend, my dear student friend, Quarter is Ali sitting in the audience. Sorry, I need to pick on you a little bit. You know this patient. Because this patient is the husband of a dear friend of yours, okay? So anyways, I put the implant in him, but the thing is this, okay? I do immediate implant placement. So I did the dual zone. I put the xenograft and the allograft right here. You see that? And then this is the dual zone. I want to show you something interesting. Okay, so again, after implant placement, I pack the gap with xenograft. Then, we put, allograft on top of it. Okay, I want you to show you something interesting. Do you see some redness right here? He always asks me, how come there's some redness there? And then it always happens to your friend, when you do surgery on your friend. How come there's redness? It won't go away. And in fact, if you look at it here, this is 3 years, there's still some inflammation. Okay, I noticed that when we do the dual zone grafting technique, at least under my hands, 10% of my patients have some degree of chronic inflammations right there. Why? I believe sometimes when you use bone graft particles there, even with allograft, if that doesn't resolve 100%, it may irritate the tissue a little bit, all right? So I just want you to know that if you use this path direction, you may need to think a little bit more carefully on that. Okay, so quickly, before the break, we'll take a look at this patient here, all right? So she's a prosthodontist, like I say, and the buccal bone is compromised. How do I know buccal bone is compromised? This is what I do. I do bone sounding first, and if it's more than 3 millimeters, the next thing I do is I take my periodontal probe and bone sound the line angles, as well as the bone of the adjacent teeth. Why? Because once I know there's a defect, I want to outline the shape of the defect using my probe. And basically, this defect looks like this right here. Why is this defect, the shape of the defect, important? Because, in this article published in 2007, that's what the authors tell us. They ask themselves, if you extract a tooth, the buccal bone is compromised. Does the width of that compromised defect play a role in if you still put an implant immediately in a socket with compromised buccal bone and do bone graft and tissue graft, will the result still be good aesthetically? So, in this study, they look at 3 shapes of defect, and they still do immediate implant placement on it. The first is a V-shaped defect, like an inverted V, a narrow defect. Or a U-shaped defect, like an inverted U-shape, a wider defect. Or the Y-U-shaped defect, in which not only the buccal bone is compromised, also the bone is compromised, that of the adjacent teeth too. What do you think will happen to the facial gingiva when you have defects like that and you do immediate tooth replacement? This, in general, is what happened. Key point we learn now is this: buccal bone is not always needed to get good aesthetic results. Remember I told you, on the facial aspect of the tooth, the bone is often not needed to set the tone of the facial gingiva. However, in a Y-U-shaped defect in which the defect encompasses that of the adjacent teeth bone, that's when you need to tell yourself, this absolutely is not a good case to do immediate tooth replacement. So, what are the guidelines if you have a patient, the buccal bone is compromised, okay? And the next thing you need to ask yourself, does the depth of the defect, that means how deep the defect is, buccal bone defect, play a role in aesthetic results when you do immediate tooth replacement? This study tried to address that. What they did is they looked at 25 maxillary anterior teeth, measuring with buccal bone defect, measuring the depth of the defect on an average 7 millimeters up to 12 millimeters. This is what they find out. In general, the key point to bring home is, doesn't matter how deep the defect is. As long as the defect is not wide enough to encompass the adjacent teeth, you can, in fact, do immediate tooth replacement without negative results. Now, this is a general rule to bring home. Number 1, buccal bone is compromised, the adjacent teeth bone must be intact. Number 2, despite no buccal bone, there still be at least 35% or more of the implant being engaged to the bone. Number 3, again, without buccal bone, your implants are placed within the concavity of the defect. If you follow these rules, you should be able to get excellent results. So, quickly go back to our prosthodontist, and then we'll take a break here. Immediate implant placement, like how I described to you. Now, remember this patient has no buccal bone. I tunnel a piece of what we call contour connective tissue graft with a cross-link suture. Does tissue graft work? This article believes so in 2009. What they did is, in a group of patients, they did immediate implant placement and provisionalization with connective tissue graft. This is what they find out. This patient is a hygienist, by the way. Hygienist, extracted her fractured canine, immediate implant placement, this is a provisional, create a tunnel, separate the bone to the periosteum, tunnel a piece of connective tissue graft here. This is before fractured canine. This is 15 years follow-up. If you look at the phenotype visually, this is what you see. Okay? Now, one more study. This is a Straumann study, randomized controlled clinical trial on a group of patients that need front tooth immediate tooth replacement. The difference is one group, immediate tooth replacement without tissue graft, and the other group with tissue graft. And they measure the recession. This is what they find out. They look at Straumann BLT implants. The group without tissue graft has greater facial tissue recession than the group with. All right? Then I'm going to drive one more point, and we will take the break. Final restorations. I treated this patient, 17 years ago, so there's no angle channel abutment, but I'm going to use cement retained restorations here. A lot of you know that subgingivally, this area, the contour, we call that the subcritical contour. Whereas the area from 1 millimeter subgingival to 1 millimeter supragingival, we call that the critical contour area. Now, in 2022 today, if you're a periodontist, this is a big deal. Why? Because the last, I would say 3 years, there has been so much talk about contour and its relationship to periimplantitis. Contour, crown contour and its relationship to periimplantitis. Why? Because in 2019, an interesting article published by a dear friend of mine, he's a periodontist. At that time, he was a graduate perio resident at University of Washington. He's Japanese, his name is Kawaguchi. So Kawaguchi published an article, and subsequently, 1 year later, Frank Schwartz, who is also one of the leading authorities in periimplantitis studies, also published a similar type of study design. And in the periodontal world, this is big. Because they say that the emergence angle of the crown, that means this is the emergence angle. That means from the platform to the contour, that's called emergence angle, the degree. And then the emergence profile is the shape of how the crown emerged from the implant. Emergence profile can be straight, concave, or convex. Got it? This is what they talk about in the periodontal world. If the prosthodontist crown emergence angle is greater than 30 degrees, and if the emergence profile is convex, based on the study, both studies, the chance of periimplantitis is about 35%. That is huge. So what did that teach the prosthodontist or restorative dentist? Number one, this is what I learned. A lot of times when the crown have exaggerated emergence angle or exaggerated emergence profile, do you know what caused that? It's because improper surgical implant position. Just imagine if the surgeon put the implant too shallow, the crown will be like that. If the implant surgeon putting an implant too far mesial or distally, one side is going to be cantilever, you understand? And the emergence angle becomes exaggerated. But let me tell you, to urge you also, my dear friend and former student, any one of my former students are a dear friend of mine, right? You know, I'm always curious. I say, is that true? So we decided to do our own little study, okay? We look at the unique thing we separated on this study, the anterior crown with the posterior crown. Again, this article published with my dear friend, who's a periodontist graduate, with another dear friend of mine, Homley Wang. Alberto Mulhane is probably one of the youngest upcoming authority in the field of periimplantitis. So when we look at this group of patients, okay, how often do we get periimplantitis? When we look at the emergence angle profile on maxillary anterior implants, and all these implants are platform switching implants. Let me show you what we find out so far. We look at 67 maxillary anterior implants. Mean follow-up time is almost 5 years. So it's long-term follow-up. Interesting thing, 50% of the crown has emergence angle greater than 30 degrees. Wow. 50% of those maxillary have emergence greater than 30 degrees. And if that's the case, then we must have a lot of periimplantitis, but not really. 5% of them have, only 5% have periimplantitis. And none of those have emergence angle greater than 30 degrees. In fact, when we dissect the data further, we look at the emergence angle at facial, lingual, mesial, and distal. Guess what? The facial has the greatest emergence angle. Do you know why? Do you know why? You guys know why, especially if you're a restorative dentist or prosthodontist. We want to put the implant in the aesthetic zone more palatal. So the facial always come like that, you know, understand? Because you don't want the implant too facial. But surprisingly, we're not getting massive amount of periimplantitis. Why? Because I think this is the reason why. How often we have a convex situation, emergence profile? Rare. Majority of them are concave. I think that's the reason why. All right? So in general, if you have a crown, even your emergence angle, I think is not as significant as the emergence profile. Rule is now you want the implant to go straight and then concave and come out like that. So patients can cleanse. That, in my humble opinion, will minimize the chance of periimplantitis. So finish our prosthodontist, definitive crown. This is a 16-year follow-up on the same patient. I'm going to put a bet that my dear friend Quarter also know her. Because I think once in a while she starts showing grad prostate teach. Okay, but I'm not going to mention name because I don't want her to be embarrassed. But anyways, you'll see that the 16-year follow-up, I want you to look at the contour. Is it perfect? No. But mind you, this patient, remember, no buccal bone. No buccal bone, I did immediate, and there's the results. And when you look at the corresponding radiograph, this is what you see. So what did you learn? Buccal bone is not an absolute must for immediate implant placement for aesthetics, as long as the bone is, not wide enough to encompass the adjacent teeth. And then, of course, you can do the bone grafting and tissue graft to maintain it. I think this is the perfect time to take a break. Thank you so much. Thank you.